when talking about quitting smoking, if he does get on board, he forgets. He only smokes 10 cigarettes per day, and that's not because he wouldn't like to smoke more. That's all he can afford, and that's what I find in British Columbia with the income that many of our seniors have, is they can only afford to smoke 10 cigarettes a day, so they're actually living in withdrawal most of the time. His family does provide him the cigarettes, and although the facility is supposed to be smoke-free, and he is supposed to go out to off the property, he doesn't do that, and with his dementia, it's becoming a safety issue. Certainly the staff are aware of the harmful effects of secondhand smoke, but they also feel that this man lives in this facility, it's his home, and not getting 100% buy-in from the staff. He has tried nicotine replacement therapy, but it doesn't seem to reduce his cravings to smoke. So the main issues is helping patients with early dementia quit smoking, and also supporting staff in long-term care facilities to increase compliance. And I'm really wondering what's happening in other areas of Canada with this, because I'm sure we're not the only ones that are experiencing this. So the only other presenting condition is he does have high blood pressure, and he has trouble with mobility. So when he goes out to smoke, he usually uses a wheelchair because the pavement, he's unsteady. So that's my case.
Okay. So, and if I can just quickly read through, this is Peter. We're just going to say that obviously he's got high blood pressure, and he's on a couple of antihypertensive medications. But other than that, there's no other medications that he's getting. No pain medications, no medications for behavior or anything like that.
No.
Okay. Thank you. So I guess, you know, the way we approach smoking behavior is that people will smoke for a variety of reasons, and roughly you're looking at environmental factors that either promote or inhibit smoking, and that includes the physical environment, the social environment, the financial environment. If you broadly look at that as a determinant, those create opportunities and restraints as to how much somebody consumes, whether they smoke at all or not. The second piece, and so we need to think about that, especially when people end up losing their autonomy and live in places like nursing homes or assisted living. Second sort of frame in which we look at it is obviously what are some of the biological determinants that drive this person smoking, including, you know, the actual addiction to the nicotine and withdrawal that's driving it. But beyond withdrawal, what are some of the other factors that drive it biologically, such as which are part of the addiction, which are things like the habit or automaticity of the behavior. So just simply responding to cues and triggers, which are not, you know, which are not consistently under the control of volition. They'll just happen. Lastly is obviously stress, and then co-occurring conditions that interfere with biologically determined conditions that will interfere with somebody's ability to stop. So whether that is any kind of alteration of mental state, either because of head injuries, dementia, or, you know, mental illness like schizophrenia or depression or other addictions, we need to think about those frames as well. And lastly which is important, is obviously, and important because we do believe in autonomy, is the motivations, so the desires for that person to change or not change. And roughly we start thinking about those factors, and then within those factors we also have to look at who might be some of the vectors that are promoting the cycle for whatever reasons, good or bad, not wanting to cast aspersions, but the players who actually then drive this, which are separate from the individual. So whether this is a facility that pays for tobacco and buys tobacco, or family members that buys tobacco and pays for tobacco, or and doesn't pay for the treatment, all of these create those sort of issues that we need to consider when looking at this. So when we're looking at one thing, one of these issues that come into the environment, which most healthcare centers have done, and we, if you look at our website, we have resources for long-term care facilities going tobacco-free. There's a literature set there that you may look at. We've also now starting something at CAMH more for facilities going tobacco-free, and after this call, we can certainly share that with you. It's one of our portals called Portico, and it's really to create the support for implementers of tobacco-free policies to develop a community of practice. So that's in early stages of development. So clearly, not to belabor this case, we want to make sure that there's tobacco-free policies, because evidence certainly supports it. And overall, we do know that it improves the staff and client physical well-being. The issue around quality of life and long-term mental health outcomes, yes, but does that actually, in the short term, create some distress to people's quality of life, because they may be experiencing withdrawal, they may be reaching into behaviors that we don't really want them to, such as smoking when it's dangerous, or smoking on the picking butts off the ground, or things like that. Of course, we do know that nicotine dependence should be addressed, but it doesn't always get addressed, because many clinicians don't know how to manage this. So, those kinds of lack of knowledge undermines tobacco-free policies. Theoretically, one should get a reduction in exposure to environmental tobacco smoke, but if you've got a large volume of people who are addicted, all clustered in a particular facility, and now there hasn't been a good clinical response or enforcement of policies, you get smoking happening in places where it's more dangerous, such as smoking and hiding it in the closet or on the bed or under a cover, and especially with people with compromised mental functioning, it might lead to fires and things like that. So overall, yes, you may get a less exposure, but one has to be careful of some of these situations might still persist, and what does require a response. But what is often, especially for people who have the ability to make a choice, controlling that stimulus of exposure to cigarettes and tobacco paraphernalia will increase somebody's ability to quit and reduce their tobacco use. So we know that at least in household smokers, living with a non-smoker doubles your chances of being successful when you make a quit attempt. So we don't know if that is actually true within assisted living facilities, but one would imagine that if you have access to the stimulus, and the stimulus is in front of your face, you're going to use it. So in part, when you take a look at why do facilities end up having difficulties with these, it's obviously, that often staff believe we are violating a client's rights, that they have a right to choose and oppose tobacco-free policies. This is their home. And again, unfortunately, this negates good clinical practice and perpetuates stigma, although the Supreme Court has come out that when people are in facilities that are publicly funded and have many other people there, then the overall good needs to be considered versus the individual rights. And smoking, although that's what the tobacco industry wants you to believe, is not a right, it's a privilege. And so therefore society does have a role in regulating where and when it cannot be used. It does it similarly with alcohol. We don't permit drinking in a park or walking down the street intoxicated, or drinking and driving. So society does regulate the use of substances and certain circumstances, either through policy or through cultural shifts and norms, but it does do that. But this is a common held issue. Most facilities have faced this one time or the other, and it often negates good clinical practice, perpetuates the stigma that this is the only pleasure that people have. You can't actually help, you're taking away their only last remaining pleasure, and it creates some of this under-treatment or lack of treatment. Often, we also have to understand that tobacco use can sometimes be a mechanism for socialization or even getting fresh air, because a person who smokes is often taken out more frequently to get that. It's also, there's also a benefit to the staff, because the staff who goes gets a break from the work as well. So the culture has to be addressed as well within the facility, not just what's on there, but it's also the staff's own use of tobacco, whether they co-use with the patient, whether they use this as a way to to sort of shape patients' behavior, so that if patients behave a certain way, then they get cigarette breaks, and if they don't, then they get punished. So one has to be careful about the culture and understand the culture going on in that facility, and what does tobacco mean in that facility, and how it's regulated or used. And then, of course, forced tobacco bans. There's often a fear of client aggression if people are forced to quit, and that people might leave against medical advice or get hurt. And clearly, all of these are possible and do occur if one only enforces a ban without actually having some way of treating the clinical presentation that people have. So in part of, the evidence suggests that having a total tobacco ban, not a smoke-free ban, total tobacco ban where no tobacco is on the property, helps reduce the stimuli and improves the outcome overall, as opposed to allowing cigarettes to be kept either at the nursing station or on the property and people have the ability to smoke. Overall, one should see a reduction of that. So within that context, one should change what are some of the reinforcers that promote non-smoking activities. So whether there's more socialization that does not involve tobacco use, or more positive reinforcement and more reward for those who are not smoking, certainly starts increasing the desirability of not smoking. So that cultural shift, and whether it's staff policies, that even staff, one reason why productivity goes down in healthcare centers where smoking is allowed by staff is because people take more breaks, and they often off sick more. So as a result, there tends to be this resentment by the non-smoking staff towards those who smoke. And thinking about how one can reinforce or reward non-smoking behaviors as opposed to punishing those who smoke might also change the culture within that setting. So therefore, leadership involvement is critical with this, including health human resource planning. Partial bans, as we said, are really not a good idea, and so one needs to have a total tobacco-free policy. Staff education to understand two key issues. In situations where people find themselves, where they are not volitionally coming to quit smoking, our ethical duty is to recognize nicotine withdrawal and manage the nicotine withdrawal for moments and times when the person is unable to smoke. So you don't have to compromise your policy of having tobacco-free, but you do need to provide management for that acute withdrawal. And that doesn't only mean nicotine replacement. That means nicotine replacement plus other activities that control the stimulus, that create distractions, that create so all of those are as important as simply providing nicotine replacement. For those who do and are able to make a volitional decision to quit, then treatment needs to be offered and available for that population. So in these settings where we find ourselves, there are two goals. One is management of nicotine withdrawal, and the other is quitting. They are not the same thing. And then again, helping staff understand this. To this day, just the other day, we came across an oncology nurse, actually, who does not believe tobacco causes cancer. And it was quite an interesting conversation because in her experience, she's saying lots of people smoke, not everybody gets cancer, so therefore it doesn't cause cancer. And it took us a little bit of convincing to get her to see how tobacco is harmful, because she actually had a patient who was 33 years with lung cancer who she was not providing the intervention. And it was not because she didn't think this person could benefit. She just said, this is not the reason why this person got cancer, although the person had a 30-year history of smoking. So we have a lot to do in the healthcare system of making sure that basic fundamental knowledge about tobacco addiction gets through. In smoking and dementia, it's very difficult to find any literature that suggests what we should do on how to help people with dementia quit smoking, or people who are not able to consent, how do you help them? However, one does need to know that in the meta-analyses that smoking is associated with the development of dementia and Alzheimer's. It previously used to be thought that, well, actually this may be protecting people from Parkinson's and dementia, but it might have been that, you know, one of the reasons that these people ended up living is all the people were not living long enough to develop these conditions. So one of the things we need to think about is that the evidence that, you know, overall smoking is causative, and whether it's active smoking or passive smoking, there does appear to be a dose-response relationship, and the risk subsides with cessation. So for dementia prevention, not only is good blood pressure control a good important factor, but also smoking cessation is another important one to engage with. Now, what to do when people are you know, addicted and have dementia? What do we deal with that? I think I'm going to hand this over to talk a little bit about motivation interviewing. And motivation interviewing here in the situation might not be for the patient. It might be for the family members. It might be for the staff. It might be for the care team, as opposed to the patient themselves. Do you want to?
Sure. And just to tack on to what Peter has just shared, there's also when we're interacting with the client that we use that spirit of motivational interviewing as well. And Nancy, I just, when you described the case, I heard you say there are some times when this person does get on board, and it's during those moments that, and I'm even thinking other moments that if we use our spirit, that we can engage the client in a way to talk about what's driving the smoking. So as Peter has mentioned, we also want to use our motivational interviewing strategies when we're working with the family, the staff, and even leadership. If I think about you know, when we went smoke-free here, we were able to provide smoking cessation medications to staff who are smoking. They had access to groups to address those other components, the environmental, the emotional and behavioral triggers to smoking. And then also there was this drive to talk to staff about what they were feeling, talking to residents about what they were feeling about this policy going down. And then also we have people who walk around the grounds and engage the clients in using their motivational interviewing skills. And a lot of times those individuals are people with lived experience. They're connecting with those clients and just giving them a reminder, alerting staff of the clients who seem to engage in this behavior more, and having a conversation with them. So even when you have a smoke-free environment, you will have people who will be smoking, and it's really important for us to engage these clients in a way that's respectful and accepting. And so we want to use our engaging principles. We want to use open-ended questions, affirmations, reflections, and summary statements. So I'm sure this person has changed in their life before. Now, you talked about there were issues with short-term memory. So I'm wondering, even in those, you know, any kind of interaction you have with this person, in that moment, they will get an idea of, you know, are you listening to them? Are you being compassionate with them? Are you trying to have a conversation in a way that allows them to share their thoughts. So even if they have those issues where they're not here or can remember what they said 5 minutes ago, at least in those moments, you can have those conversations. And if I think about I'm going all over the place, I hope this is okay. If I think about the nicotine replacement therapy and this person still smoking on top of that, is this person getting enough? What's driving that smoking? And I know we also want to elicit from the other people attending the webinar, so I'll try to just keep myself back a little bit. And really engaging with the client and in those moments being respectful and trying to elicit from them what could help them in the moment. And so you can see these examples here, engaging, focusing, evoking, and planning. And just to tack on to what Peter had said earlier, that idea of, for this person who may not want to make that change, it's communicating that idea of, hey, I just want to help you feel comfortable in this environment, and then talking to the family a bit more about things.
Just one thing that I'd like to add as well is just realizing that this is an ongoing process. It's not something that it'll be one sort of conversation, but it's something that will happen over time. And again, really reiterating what Alex has said is just, to continue to ask them what it is that they really want, and then start from there. I think that's really important, or what their understanding is of this whole process.
Mm-hmm. I mean, I think about people who are mandated for treatment, and there's that idea, like, you're stuck in this environment, you may not like it, but how can we make the best out of this situation working together? Mm-hmm. So this kind of idea.
So now here we would like you to participate. So let's just do one question at a time and just say, let's go focus on question one. So please start typing. The question is, from your setting, how would you approach this client given his level of tobacco use and ambivalence or inability to quit?
And if you've joined us via teleconference and you'd like to share your thoughts, please just push *1 on your telephone to unmute so you can ask your question, and then when you're finished, push *1 again to mute yourself.
We got a lot of people typing.
So, we'll just start, while you're typing, we'll just look at some of those issues that came up and think about, the idea of who are the players here. There's the patient, there's the family, there's the care provider, and management, roughly. Right. So yeah, so what we're seeing is that people are actually not, people with dementia don't, it depends on the severity, and not always, sometimes eventually dementia gets so bad that they forget to smoke, but when they're in this early stages or they've got mild cognitive impairment, they can still do some planning and still have a conversation. They may have inconsistent follow-through, but so asking them and tapping into their values about what they want and how they want to do this is equally important.
And I'm even thinking too, what do those cigarettes represent? Because you had shared earlier, Peter, that idea of, you know, independence. Like when you're living not in your own home, is this the way for this person to feel independent? And then I thought of the family, and I thought, well, is there a guilt thing with the family too?
Right. So there may be other dynamics going on that are driving. I think, and this is the issue, is paying attention to what are the dynamics that are keeping the smoking going. And I think, again, you know, is this person ever quit before? Is this gone up? Has it gone down? Is it, you know, and as you said, he's restricted to 10 cigarettes a day because of cost. So thinking about that, what are some of those drivers as well? We're talking about the use of nicotine replacement, and here's whether you call about a harm reduction or managing acute withdrawal, thinking about how one might approach it. So the other day I had a similar patient who I saw here in the clinic, and in fact he is he's not only, he has dementia, he's young, but he's got significant dementia plus a schizoaffective disorder plus incontinence and wandering and very poor hygiene. So putting a patch on him was not going to be helpful because he would just pull it off. And so we were thinking about what would be the best nicotine replacement, and we had to think through that he had very poor dentition. He had extremely bad oral hygiene. He had his front teeth were missing actually, and weren't sure that he would be able to chew the gum or whether that would be a choking hazard for him. So we thought possibly the lozenge would be one option. Clearly the inhaler would not do it because it needs, one needs to load it and hand it over, although if there is a caregiver who he can, is with him, he could have done it. He did not have that opportunity. So then there came in the mouth spray, because that's a passive treatment. You know, as long as somebody primes it, all he has to do is open his mouth and somebody can spray it. So and if he's able to do it, then that's something he could use instead of cigarettes. So there's no randomized controlled trial showing what we should do here. So this is all about coming up with ideas. And so those were the nicotine replacement treatments we thought about and may need to be considered. And I think I want to go back to what you said, Alex, is that often we under-medicate individuals. So we think that, oh, well, we've given them the nicotine replacement, one patch, and that should stop them in their tracks. And often when we have to move the dose up and down to get to the right dose. And often we do allow them to smoke on top of it because we're trying to figure out what their actual dose is. And it's tough to know. Blood tests can help you, but they're not easily available to know what to do. And the number of cigarettes they smoked is only a rough indication of how dependent they are. Just because this guy is smoking 10, it's possible that he was actually, he's pulling out way more from that 10 cigarettes. And he may actually, if he had access to cigarettes, he may actually be smoking 20. But because cigarettes are elastic, you'll end up, people can be smoking them to, really efficiently in a sense and getting a lot of nicotine. So.
And if he's just having those 10 a day, he's probably really efficient, taking it
possibly
from beginning to end.
Yeah, one way to know is to get the carbon monoxide level if you have that machine, because if you get an exhaled carbon monoxide and he's smoking 10 cigarettes but he's still blowing 20, 30, 40 parts per million, you know he's compensating, and because he's definitely getting a lot more of the carbon monoxide from that. So that's another sort of rough indicator that he may be he's compensating on his smoking.
And he would be able, sorry, Tania, and he would be able to tell us, you know, if smoking on top of the patch was making him sick, because that's pretty quickly he'd be able to say, oh yeah, I felt like vomiting outside if he was asked about that. And that could also help us titrate that dose faster. And I'm wondering, could this person even be on Champex if in those moments, like in that family meeting, and with the client being there, if that could be a possible intervention. Sorry, Tania, go ahead.
The only thing that I'll add is just it's really important to ensure that other people are involved. So the question is, how would we approach this client given his level of dependence and ambivalence, but really important to get other people those supports to also help. So it's not just yourself and this client, but also the family and the staff members, ensuring that everyone's on the same page or has a great understanding, a better understanding of what it would be to try to help them to move forward to quit smoking.
Yeah, I totally agree, especially because the family is bringing in those cigarettes. And we've got some great ideas that people have shared here too.
So we've talked about the family there. We can see the families coming in there. What are the barriers that are in the facility itself? So you can look at the ecosystem. So facility, from management to staff, all those dynamics, the places where smoking, how do cigarettes get into the facility, even if the family gives it, who's actually handing it out to him? Is he allowed to keep it on himself? Is it, who's lighting him? Who's supervising him? Because, you know, the big issue with this is fire risk. There have been cases in Ontario where people have been, with significant dementia, have been put into smoking rooms when we used to have them, left there to smoke, and they burnt themselves to death because, you know, cigarettes are number one cause of house fires, and a lot of people can burn themselves. In fact, the individual I saw 2 days ago was his entire shirt was full of cigarette burn holes. So, you know, so thinking about that as well, the fire risk, and there are some aprons that are there in places where that you can reduce that risk of fire that the person gowns if they're going to smoke. So there is that issue to pay attention to as well. So the question is, you know, staff initial response is, what else do they have to look forward? Why help them quit now? So I think the main issues to get people to think about it is that when people at this level are smoking, they're not smoking because of the, you know, the inherent human issue to experience pleasure. Right now, if they've been, you know, smoking for that long, it's primarily to keep themselves out of withdrawal. And so because we don't manage their withdrawal, that's why they smoke. And so you know, a good, aggressive management of the withdrawal, appropriate management of the withdrawal, is not taking away a pleasure. In fact, you may be enhancing pleasure because now they're no longer a slave to having to do this, and most long-term care facilities aren't able to allow people to maintain their nicotine levels through cigarettes. It's just not feasible, so they'll end up, you know, going through withdrawal, picking butts off the ground, hiding, etc. So is that better than managing their withdrawal appropriately? So there's a little bit of education we need to do there.
And even connecting on that question of what else can people look forward to? And I'm thinking if in this case, for someone who doesn't have a lot of money, in those lucid moments, in those conversations with the family, you know, hey, you know, maybe this could be money used to go see a baseball game, maybe money to be used on something that they may enjoy but they don't have the funds to buy. And so connecting on that issue of, you know, what's good and not so good about smoking, and tapping into that area of, okay, these are some possible positive gains that could happen if I had a bit of cash. And I'm thinking also with the last webinar too, is this person, if we think about the cigarette too, it's been with that person for so long, would they feel like weird about not having that cigarette anymore?
Yeah.
And once again, as I say this, like I don't, if someone still has some cognitive abilities, this will be an easier thing to do.
I want to just point your attention to what Mark Baribeau has been typing. Really, this is when you have people who, addictions affect the affective parts, their feelings, appetites, etc. And our treatments typically are cognitive, which require thinking. Mm-hmm. When that's compromised, our treatments will have to be way more behavioral than cognitive and pharmacological. It's very difficult to get the cognitive level. Even without cognitive deficits, most people have difficulty quitting smoking because the cognitive efforts are hard to use consistently. But in this situation, it's important that people map out when and where the person smokes and how could you start a fading proposal. So simply by cutting out, this is a tapering protocol of cigarettes, because if the person is already losing memory, then just simply keeping them comfortable and letting that nicotine just sort of, whether it's with nicotine replacement or not, but a fading reduction of cigarettes over time, so that there's a new behavior that now is getting reinforced and the person doesn't even remember that they smoked. And burn holes are, I guess, so regular cigarettes continue burning even when they're one and not in use. So I don't know whether you can get, special cigarettes now which don't have burn holes. My understanding is that every cigarette has the rocket fuel accelerant, and that keeps the cigarette smoldering. And so I don't know if there's a particular brand of cigarettes where, this would happen. Now, where you wouldn't get this happening, obviously, are with electronic nicotine delivery devices or the inhaler, but again, those are not necessarily proven, ways to do this. So that is something to think about. Yeah, and any burn holes that occur in somebody, there's a high risk of fire for themselves and others. So I think one needs to think about it. And I guess as the discussion's occurring, one needs to think about the ethical things. Do you give cigarettes, or do you actually do you provide effective forms of cleaner nicotine instead of cigarettes to the individual?
Which goes back to your point of if someone was in alcohol, you say that differently, but if someone was in alcohol withdrawal, most likely they would receive medications for that. There wouldn't be okay, let's bring in the 12-pack and go have a drink outside. There are facilities like that, but that doesn't happen very often.
Right. And it just depends on what the philosophy of the facility is.
Yeah.
Right. Okay, let's move to the next question then.
So the next two questions, behavioral and pharmacological approaches you would recommend, as well as how you would involve or address the family. They've kind of been touched upon, but if you have anything else to add to that, or should we move on?
I do have something to add. I think just to restate, I think it's really important for the facility. Peter, you had mentioned before about having some sort of activity so clients can be bored. So ensuring that there are things that will help to occupy their time, to distract them. So we talk about many times the 4 Ds, and delay, distract, drink water, deep breathing. So the distraction is a really good piece. And then with the behavioral in terms of delaying, so we can help, that would be another strategy to help them to reduce smoking. Yeah. I'm just trying to read and speak at the same time.
So I think, regardless of what you do, if you've got people with cognitive impairment, regardless of the cause, using a lit product is going to be the most dangerous. And you've got to think about overall risk to self and others in the immediate. Are there safer options? And not shying away from managing the tobacco use and switching to a less harmful. Now, of course, can't leave them with a vaping device, and if they light it, that certainly it does become problems. But often redirection, as Madeline points out, is required. So I think, answering that question or thinking about that question about how to handle pharmacologically, we talked about look at the medications, manage the nicotine. So if the person can actually have a patch and it'll stay on and they'll keep it on, then yes, and you can supervise that, then that's probably the best, even if they smoke on top of it, because if they smoke on top of it, it'll actually create a little bit of an aversive experience. They will actually put the cigarette down and not finish it. They tend to be responsive to that. That kind of learning is a much deeper learning and doesn't require cognitive learning processes. So initially, that kind of smoking with the patch on, and actually that has shown in people quitting smoking, has shown to work much better, maybe twice as better than those who try to quit and put the patch on their quit day. So pre-cessation nicotine replacement has got good evidence behind it, and in part it could be because of this. So I would suggest that you look at what kinds of nicotine replacement and are people being adequately managed on nicotine replacement till they literally extinguish the smoking behavior. They're not thinking about it, they're calm, they're cool, and then gradually taper the nicotine replacement down. And clearly the behavioral issues that are coming up in the conversation, look at that in terms of looking at redirection and stimulus control.
And I'm thinking, too, additional supports would be maybe a group that runs in the building where this person is living, so that people who are in the same boat are trying to make this change, and they can discuss things. And if people have to mill about, or because you would know best the cognitive abilities of individuals, but maybe it's just about doing activities and talking about how these activities could maybe help you, like, not think about smoking. And then if I think about the family, eliciting from the family, what are those bringing those cigarettes about? What is their knowledge about tobacco use? Because I'm even thinking this person, it's dangerous for them to go out, and maybe they could even have another stroke on top of their dementia, which will then make it even more problematic for them to function, or maybe their circulation will get worse, and then their mobility will be even worse. So talking about these issues with the family and trying to get them on board, because then they can also be an additional support. Tania, did you want to say about family stuff? Okay.
Yeah, I think so.
So the last two brainstorming questions are looking at kind of eliciting some of the strengths to enhance this client's motivation, and lastly, identifying barriers and solutions to tobacco-free implementation.
So Karen has shared a really good summary of how they went about becoming smoke-free. Sorry.
Okay, someone just asked if we could see the questions again. So Phil, here they are. You can also download the slides on the bottom right-hand side of the screen right over here so that you can have them in front of you. I do need to make the chat bigger so we can all see. So I'll just leave this up for one more second and I'm going to put the chat back.
There was, I'm not sure who, oh yes, Michelle, that was interesting, using pictorial resources in terms of developing a plan and understanding safety and issues.
Yeah, I think that's really when people have cognitive deficit, it could be language, it could be just a deficit. So what we are in addictions in general, often people look at people having lack of motivation, and it might look like that because they may be going back and forth, but it may actually be a lack of ability, and that is one thing to always figure out as to whether this is lack of ability because of some sort of fixed cognitive deficit like a head injury or dementia or stroke or what have you, or is it actually a lack of motivation where they are ambivalent because it's a conflict of personal values. So that's one way to think about it, and then you can start thinking about how you could approach this. And sometimes, yes, the other day I had to work with the substitute decision maker and lay the pros and cons of, clearly the patient wasn't able to consent to the treatment, but we had to lay the pros and cons of what if we did nothing, and what would continue, what are the pros and cons of managing this, and then of course the key question is, well, if this is that person's only pleasure, are we taking it away? And it required some education around how much of this is actually pleasure versus how much of it is withdrawal termination that the person is in a cycle of, and that we are actually, by not addressing it, restricting that person from a whole host of issues such as placement in a particular potential better place to be, or or money for food or clothing, etc. And not dying from a fire or a burn. So those are some of the things that we went into that decision making with the substitute decision maker.
And Phil has mentioned here strengths being the family, and I agree with that, because some people don't have anyone looking out for them or trying to.
So I don't know, the other one I just want to quickly touch upon is enforcing tobacco-free. We are certainly going to link you up to the Portico web, Portico through our tobacco-free initiative at CAMH, so that these are some of the things that certainly that listserv can help you with, or as it's evolving. But one way to think about it is we move away from the language of enforcement to cooperation. And so, yes, you may need to enforce it with your staff, because that's a performance issue, and certainly enforcement of staff and staff behavior is important because there's a management and staff sort of structure. When it comes to clients, we've really taken this idea of having what in CAMH we call smoke-free ambassadors, who are peers that Alex spoke about, whereas we're trying to get cooperation for everyone to see the value of not smoking and where they can and cannot smoke. But again, over time, it's helping that fade out so that people have now more pro-health kind of initiatives, so that they have abilities to engage in nicotine replacement therapies, etc. So many people have been very creative. We've heard from our STOP participants doing something like known as quit cafes, where people come and show up, and it's basically getting together in a non-threatening way around maybe coffee or tea or something like that, and no smoking is allowed around that. So, and that also creates the support for the ongoing support in an ambulatory setting like CMHA is talking about. So there are many ways in which one can think about this. If there are rec therapists, can you engage your rec therapists in creating programming that creates these things? I'm going to stop there and pass it on to you guys.
I'll come back.
Well, sort of switching gears in terms of the strengths. I know that you were talking about the enforcement, Peter, but one of the strengths that comes to mind for me and would be part of focus is this client smoking 10. And Nancy, I believe you were saying that they could smoke more if they have the ability to. So the fact that they're not asking other residents for cigarettes, or I haven't heard about picking up butts, that sort of stuff. So that behavior hasn't started yet. So focusing on some of those strengths is really important.
Right. Yeah.
I think my last comments would be really about leadership and staff, because everybody's got to be on board and really having those conversations of what are the trepidations there, what do they, what are the good parts that they see in this policy, and then as Peter had said, if, when people are breaking the rules, quote unquote, engaging them in a respectful, accepting manner, and just, I've said before, hey, I don't know if you knew this, but you can't smoke right outside of this door here. Would it be okay if you just, walked a little bit down there? And usually people are open to that, and then saying, if ever you want to get some help, no pressure, just come on by and see us at.
But that would be more for family and other members, where this person has got dementia. This is really about, they're going to be having, difficulty because of the addiction is just driving itself. So
fair enough.
Yeah.
Fair enough.
Okay. What else do we want to talk about? Okay, so just coming back, to Nancy. Nancy, I think we hope you have some more ideas of how to think about this, and some of the the chat that's typed in gives you some ideas of how to approach this from a setting level, from the individual level, both pharmacotherapy and behavioral interventions. And again, it sounds like you're going to, so you're going to need some ways to think about safety, especially the issue of from respect to fire and burning himself, and of course the family's role and what does a family meeting need. And of course, family is always wondering about loss of autonomy, especially when they have a family member in. So getting them to see this issue is important. Anyway, so some of the questions that we have on.
Thanks very much for your help. I appreciate it, and it's good to see a whole group that are on board. It really helps me work towards this in Northern Health. And I know in experience in the past, we had a lady at a residential care unit that this apparently was her only pleasure, but when she was supported to quit, she could join in and watch a movie or read the paper or play bingo, which she was never able to do because she was in withdrawal.
That's right.
Yeah, that's huge.
Yeah. We've seen that with a lot of patients in group homes who after we,